Okay. All right. So, pediatric pee. We often refer to as stupid pee. And any reason why? You know why we do that? Essentially, kids can't concentrate their urine. The kidneys don't really mature fully until about the age of 3. And so, for the longest time, we didn't do transplants up to the age of 3, which I thought was kind of interesting. But they are starting to transplant these kids a little bit earlier. I will tell you, you know my background's in oncology, not renal, but I did do clinicals on the renal floor at Children's for a long time, and I learned so much while I was there and gained such a greater appreciation for all the things that the kidneys do and how infants just really don't have the same capacity as adults. They are pretty amazing in other ways, but when it comes to the kidneys, they're just not as mature, which means they're at a higher risk for electrolyte imbalances. So if you think about it, infants, their urine is generally not concentrated. If you've changed newborn diapers, it's usually clear, right? It's very light colored, and that's because their urine output is more milliliters per kilogram per hour than an adult. Okay, so what's normal urine output for an adult? 30, right? So with infants, it's actually 1 to 2 milliliters per kilogram per hour, and that's if you don't have anything going in. That's how much the kidneys will produce in 1 hour. But that's not accounting for all that they're drinking, and if we're putting IV fluids in as well. So when I talk about minimum urine output, that's without anything going into that patient. That's how much you should have out. To keep things simple, I'm not going to make you memorize, how much for an infant versus a kid. Just know that it's approximately 1 milliliter per kilogram per hour up to 30 kilograms. And we stop at 30 kilograms because we wouldn't expect, a 30 kilogram kid to put out more than an adult, right? Because usually by 30 kilograms, 60 some pounds, they're not under the age of 3 anymore, right? Hopefully. Okay. Let's talk about renal failure. I'm going to talk about acute renal failure and chronic renal failure. The good news with acute renal failure, kids are very resilient. I told my clinical group a story where we did compressions on a kid. He had a cardiac defect. We did compressions for 90 minutes on this baby. He was 9 days old. Went into renal failure, of course, because the kidneys weren't getting perfused. Ended up on dialysis for 3 days, and then the kidneys kicked back in, which is pretty impressive. With an adult, that probably wouldn't happen, but kids are very resilient. As far as chronic renal failure, with kids, chronic renal failure usually occurs due to some sort of obstructive process. And so if in utero or after birth, if you have an obstructive process that urine isn't able to get out and it's going to back up into the kidneys, and you're going to end up with hydronephrosis. You can see that on ultrasound. And what's really cool is that you can do some surgeries in utero where they'll take the fetus out, do surgery on the kidneys, and put the baby back in. So that's pretty cool. We have chronic renal failure and we have end-stage renal failure. End-stage renal failure is an extreme form of chronic renal failure. And it's usually if the kidney function is less than 15%. That's when we consider someone to be in end-stage renal failure. Okay? All right. Acute renal failure, we can fix it and they'll recover fairly easily. Chronic renal failure is going to be progressive. All right, so it's a gradual process. It's not reversible. But depending on the cause of the chronic renal failure, it may take a really slow course, or it can be a little more rapid, depending on the cause. But essentially what happens, when you've got damage to those nephrons, those kidneys will compensate, okay? And while they compensate, it can cause those nephrons to hypertrophy, so that's another reason you end up with enlarged kidneys, okay? All right. I want you to go ahead and open up your kits. You can lay things out. I used to have people build these little kidneys, but then I found there's an Oriental Trading Company. You can only buy these at Halloween time, so I buy them for the whole year. So in the spring, they're kind of hard, right? But you can see the vasculature, right? Isn't that cool? And then inside your bag, you should have a little red hot candy. You've got some red beads, but you also have a little red hot. Okay? So this little red hot candy, and I apologize if some of these are incomplete. Miss Fogg and I put these together at the beginning of the semester. And we get distracted sometimes, so if some things didn't make it into the bag, I apologize. Okay? All right. Okay, so what I want you to do, I want you to take your little red hot and put it on your kidney, and this is your glomerulus, okay? And you guys have already had your adult renal lecture, I understand? Okay. So what is the glomerulus? Okay, it's a network, a tight network of capillaries, right? And so it's really when the kidney when blood enters the kidney, this is at the very front end of the nephrons. And how many nephrons do you have in each kidney? Over 1 million, okay? So, I only gave you one, all right? But this represents 1 million in each kidney, okay? So the blood comes through. The first place it really enters, where filtration takes place, is in the glomerulus. Now, in order for that filtration to take place, you need a pressure gradient, okay? So you need to have a sufficient blood pressure to move that blood through so that that filtration takes place. So, if you have low blood pressure, if you're in shock, you're not going to have that pressure that's causing that filtration to take place. And your body has a propensity to hang on to potassium and phosphorus. Okay, kind of like pup is up. Now, pup is up is for oncology, right? And what do you look for with pup is up? What causes that? Tumor lysis, okay. The U in PUP is uric acid, okay? And the P's are phosphorus and potassium, right? Now, the uric acid is a problem because when those tumor cells lyse, the uric acid is released, okay? In renal failure, we don't worry so much about the uric acid. So it's really is up in renal failure, okay? So don't get confused with the uric acid. With renal failure, I want you to remember that this glomerulus has a propensity to hang on to potassium and phosphorus. Okay? PP is up. Okay, there you go. I like that. I'm going to hang on to that for next semester. I like that. Okay. So what's really cool, in addition to creating pee and filtering things, the kidneys do so many things. And I really kind of took it for granted until I worked on the renal floor. And where I came to appreciate this is at 9 o'clock, these kids get like 20 to 30 meds, right? They're on so many daily meds. And it's because in chronic renal failure, you have to compensate for all the things that these kidneys aren't doing. So let's talk about renal failure by talking about what the kidneys do, okay? So what's the difference in oliguria and anuria? Yeah. Scant versus none. That works. Okay. Fluid retention. Why do you end up with fluid retention and edema in renal failure? Okay. What's that? Okay. Okay. Do you learn about albumin? Okay. You just heard us over. I'm going to go ahead and talk about it now. All right. What does albumin do? Okay. Think of albumin as a big, heavy molecule that works as a water magnet. Okay, so here's my little protein molecule. All right. Here's my kidney. These are mesh panties I stole from postpartum years ago. And I lost them, and I found them, and I was so excited when I found my mesh panties. So I've been bringing these for years, okay? So if you think of your kidneys, right, as this nice little filter, are you supposed to leak protein? No. You're not. So when you leak protein, this big, heavy molecule has to work really hard to get through, right? Okay? So, let's see. So if this molecule has to work really hard to get pushed through the kidney, okay, whoops, sorry. All right, what's going to happen? It's going to make a big splash, right? Okay, because they're heavy, right? It's not supposed to leak, right? So what happens if you have all this protein leaking out into your urine? You're not going to have any left in your blood, right? So if you don't have that protein in there pulling and working as a water magnet, what's going to happen? You're going to third space. You're going to leak, okay? All right, so that's the main reason you get edematous. I had a really good question at the weekend program. They asked, at what level do you give albumin to replace it if your albumin level is low? Which I think is a great question. Anybody know the answer to that? The answer is we don't really pay attention to that. And I love labs, but the reason that we would want to replace albumin is if they're symptomatic, okay? Right? So if you're third spacing and it's problematic, meaning that it's causing pulmonary edema and congestive heart failure, at that point you'd say, okay, we really need to get this fluid off. Okay, but we don't determine that based on your albumin level. Okay? All right, electrolyte imbalances. Kids, we know, have a higher propensity to have electrolyte imbalances for a number of reasons, but the kidneys is one of them. Okay? Here are the ones that I really want you to know. PP is up. Okay, I like that. I'm hanging on to that. And the other one that you really need to worry about, and this is less with chronic renal failure but more with acute renal failure, is hyponatremia. What happens with hyponatremia? We teach you what happens with hyper and hypokalemia, which is what? Heart arrhythmias, right? Heart. Okay. What happens with hyponatremia? We don't teach you to be as afraid of it, but you really need to be afraid of hyponatremia. Right. And why does that happen? It does? Yes, you have brain swelling, and then if you don't intervene, what's going to happen? Herniation. Okay? Herniation. Okay, which is irreversible. Okay? So, I'm going to talk more about that when we talk about acute renal failure, but just so you know, when it comes to chronic renal failure, hyponatremia is not as big of a problem, but potassium, phosphorus, and if your phosphorus is high, what's going to happen to your calcium? Okay. C low. All right. Acid-base imbalances. So when we look at acid-base imbalance, just to simplify things without getting caught up in the minutia, we look to see if the cause is renal or respiratory, or metabolic or respiratory, right? So it's easy to remember that in a renal problem, is it going to be respiratory or metabolic? Right. So how do you remember that these kids are in a chronic state of acidosis? Okay. I have no idea how I came up with this. I'm really kind of embarrassed, but it works. I've been using it for years, and I haven't gotten in trouble. One of these years I'm going to get in trouble. But one day I was thinking, how do I help remember acidosis, acid? And then I was thinking, okay, sugar cube, acid. Okay? When I started teaching, there were a lot more carryovers from the 60s. Now it's a younger generation. Do they still use sugar cubes for acid or LSD?
Yeah.
Okay, so in this, okay. All right, I promise, I'm not speaking from experience. But in the 60s, right, people either use sugar cubes or postage stamps, right? For LSD, but postage stamps are expensive, so I went with sugar cubes. So, just so you know, when you think of renal failure and you can't remember, are they acidotic or alkalotic, just think of your sugar cube. And another way this can help you, what happens if you vomit a lot? And so do you end up with alkalosis? Just think of them, you're vomiting the sugar cube, you're getting rid of that acid, okay? And that's why with chronic vomiting, you're going to end up alkalotic. Okay? All right. Any questions on that? I can't believe I haven't gotten in trouble for that yet. But if it helps you, great. Okay. Hypertension. Why do kids in renal failure, chronic renal failure, end up hypertensive?
in the body causes, I know it has to do with how it backs up the kidney and it backs up the liver and it backs up the fibrosis.
Actually, I'm thinking of another reason. Like, think of adults. That process you're talking about is really more common with adults, right? Congestive heart failure, right? People can be hypertensive for a lot of different reasons, okay? In renal failure, like adults, it can be because they've got too much plaque buildup, right? They're in congestive heart failure. It can be because they're diabetic. I mean, just a lot of different reasons. Kids in renal failure, the reason that they're hypertensive has to do with intrinsic kidney damage, right? So in the response of hypotension, your body releases renin that causes what? The conversion of angiotensin 1 to angiotensin 2, and your body responds by increasing your blood pressure. So that's the main mechanism that these kids are hypertensive. Just think of it as a poorly managed renin-angiotensin system. So the reason that they're hypertensive, intrinsic renal, so how are you going to treat it? I have a little card. An ACE inhibitor, okay? So most of these kids on renal failure, they're going to be on enalapril or captopril, right? So some of you may have a king. That's because I ran out of ACEs, right? But if you have a king or a queen or a joker, just pretend it's an ACE. So you think ACE inhibitors. How do you remember that enalapril and captopril are ACE inhibitors? The pril. So A for ACE, combine it with pril, April, right? Did you learn that trick in pharm? So think April. Okay, all right. It's just how my brain works. All right. Okay, congestive heart failure and pulmonary edema, that comes if you've got chronic hypoalbumin and they are chronically edematous, okay? Now, neuro symptoms. In your kit, you have a little brain. I want you to condition yourself that if you have someone in renal failure, adult or kid, you need to be thinking neuro. You need to be looking for neuro symptoms, okay? Now, in chronic renal failure, the main reason for that is that your body is not excreting. Hey, these are for you during the break, okay? All right. All right, so in chronic renal failure, the main reason you're going to have problems is that you have the buildup of the nitrogen waste products, okay, which can cause impairment. In acute renal failure, the main reason that you're going to run into neuro problems is hyponatremia, so we're going to keep those kind of separate, okay? Now, oops, I forgot one. When you have that buildup of nitrogen waste products, you can end up with a uremic frost. You've got a little Sour Patch Kid. I used to have sour Skittles, but then I found these Sour Patch Kids. Now, the only problem with these is I have to air dry these for a long time, and what happens with that is sometimes the crystals kind of get sucked into the gummy part. But anyway, any runners in here? Any runners? Used to? Yeah, before nursing school? Yeah, I can relate. Okay, so you know back in the day, when you had free time, you'd go running on a hot day, and you come back, and you'd end up covered with all these salt crystals, right? It means it was a good workout. It means you didn't drink enough. But essentially, that's kind of what a uremic frost looks like. It's more an end stage, right? And it has a really foul odor, okay? But that uremic frost kind of looks like that. All right? Okay, so what are going to be the early signs of renal neuro problems? Yeah, they may be a little confused. That's normal. Probably all of you have taken care of an adult with some kind of renal failure. If they're in end-stage renal failure or close to death, they're just in and out of consciousness, right? They can be really lucid, and then all of a sudden they're out of it again. But you want to be on the lookout for this early, right? Start out with changes in LOC, can progress to coma, and then death, okay? So just Always condition yourself, think neuro, neuro, neuro. All right. There we go. Okay. So labs. So when we're looking at renal, people think BUN and creatinine, but what's really interesting about these kids is that there's so much more to it. So I love when we get kids in clinical who are in renal failure, these labs are fascinating. If you have someone who comes in renal failure, usually the BUN and creatinine are going to be high, right? What I want you to know about BUN and creatinine is that BUN is very variable and creatinine is very stable. So the creatinine is a much more stable indicator of renal function. And the way that I always, the best analogy I can think of with renal failure is this. Have you ever found like an old dried out sponge under your sink that's been there for years in the garage? It's this nasty, hard, rock hard thing, right? Okay. So what happens if I put this under a faucet full blast? It's just going to run right off, right? Okay. If I turn the faucet on drip by drip real slowly, what's going to happen? It's going to absorb it, right? Okay. So think of renal failure that way. Most of the time, kids will come in dehydrated. It's one of the number one reasons kids come into the ER. Usually because they're vomiting, diarrhea, number of reasons. So what do? We bolus them, right? If they have poor perfusion, we're going to bolus them with 20 per kilo, and then we're going to watch them. Okay, so what happens if we have a kid who's in renal failure and we don't know that they're in renal failure? We're going to bolus them. We usually bolus them up to 3 times, right? And then if they're in renal failure, they're just going to blow up like a balloon, and we're going to do a whole lot more damage. So I want you to think, with renal failure, proceed really, really carefully, right? You don't want to, especially when you don't know that they have a chronic problem, okay? We don't bolus them, but how do we know that they're in renal failure, right? Unless they're in chronic renal failure, then we know. But just be really careful. We don't want to bolus them if we know that they're... The main reason this comes to be problematic is when they're in acute renal failure, otherwise healthy kid, no history of renal failure, and then I'll talk about this more when we get to acute renal failure, but just think of the sponge this way. You just have to be really careful. You should, ideally, but anyone been into the ER? That's not what happens, right? And so by the time they get up to the floor, whoa, right? But generally, if a kid is dehydrated, their BUN and creatinine may be a little bit high. When you bolus them, your BUN is going to come right back down, right? It's very variable, okay? Your creatinine is a much more stable indicator of renal function. BUN is going to fluctuate. Just like, your hematocrit is going to be falsely high if you're dehydrated. You hydrate them, it's going to come back more to normal. So think of BUN that way. Your albumin is going to be chronically low, pH is going to be low in chronic renal failure. So here's hyper K. All right. So when you're sitting there at the computer taking NCLEX and HESI, just think of hyper K if you can't remember if it's high low, and then there's C low. This one with the cat. Okay. I had a former student. He was back in the old building. He's now working in HEMONC, and he said he was in chemo class, and he was able to teach the class. Pep is up in C low. So, okay. All right, so how do we treat them? All right, you guys have already been taught about dialysis. The only thing I want to teach you about dialysis is that with kids, most of the time they're going to be on peritoneal dialysis. Okay. You're taught with adults that they get this fistula, right? If they do end up on hemodialysis, it's more like a central line, like a double lumen catheter, right? Because their arms are so little. The reason that we do peritoneal dialysis more than hemo is because we can hook them up to it at night when they're sleeping. Can you guys hear me still? And then we can disconnect them in the morning, they can go to school. When you do hemodialysis, you're stuck, hooked up to a machine, usually in a dialysis center, Monday, Wednesday, Friday, which is really prohibitive. So most of the time, kids are going to be on peritoneal dialysis. Okay, how are we going to treat their anemia? Why are they anemic? Okay. Right, so in your kit you've got a little bone, right? With your bone marrow. I found these really cool ones. They're white with little red spots on them. Okay, so in renal failure, the kidneys do not create or produce enough erythropoietin, right? And erythropoietin stimulates the bone marrow to produce red blood cells. So you've got some little beads, okay? So you can just put your little bone there and your little beads. So if you don't have erythropoietin, you're not going to be producing enough red blood cells. Now, what's really interesting about this, when I was on the renal floor at Children's, these kids were walking around with a hemoglobin of 5. I think I talked about this in the last lecture. These kids can compensate pretty well. You think, how can they even walk around with a hemoglobin of 5 and 6? If those were oncology kids, we would be transfusing them at usually 8 or 9, right? The reason we don't goes back to that HLA typing. Every time you transfuse a kid, they're exposed to antigens that then kind of hang out there on the cell surface. So when you go to find a donor, even if they are HLA typing matches, if you have a lot of antigens, those antigens are going to attack the new kidney, right? So just to minimize that exposure, we don't transfuse these kids, and we treat them with erythropoietin instead. Okay. All right. Osteodystrophy. If you're in renal failure, your phosphorus high, your calcium's low, how is your body going to compensate for that? Yeah, your body is going to pull it from the bones, and it's all tied up with parathyroid hormone. You don't need to know all the details. Just know that that's how your body compensates. If your calcium levels are low, it's going to pull it out of the bone, and what happens, you end up with a really porous bone, right? And so these kids, short stature because of that, and their bones are really brittle, right? Just think of them as like, instead of a nice, tight, strong matrix, think of them as like full of holes, okay? All right. Tied in with that, these kids are going to be on calcitrol. Calcitrol is a vitamin D analog. And in order for the calcium, here, oh, I don't have a Tums. Okay, you guys have intestines? Some of you may not have intestines, and here's why. When I ordered these kits, you can't buy just kidneys or just brains. They come in a kit, and you're supposed to have 11 of each, right? But for some reason, they're pretty skimpy on the intestines. So I usually end up with extra kidneys and extra hearts, but not enough intestines. But you should have a Tums in there. I don't have one. When you ingest calcium, all right, it goes into your, Tums are high in calcium. All right, you ingest that, and then you need that active vitamin D in order to get that into the bone where you can build that matrix. You need to have the active form of vitamin D, right? Your body has to convert it. In renal failure, your body isn't able to convert it, so those kids are going to be on calcitrol, which helps with that. Just giving plain vitamin D is not going to be enough. And then with chronic renal failure, the ultimate goal is for them to get a transplant. Now, what's really interesting is that the sicker you are, the higher up on the list you are for a transplant. And so you have this interesting dynamic in that when kids come out of the ICU, usually that's a good thing, like, yay, but it's really stressful for these families because when they come out of the ICU and they're on the floor, it means they drop down on that transplant list. So that was a surprise to me when I was on the floor, because usually you celebrate them coming out. And then if these kids are deficient in growth hormone, we do put them on growth hormone, which may or may not help. Okay. All right, diet management is really confusing with renal failure. A lot of it depends on the cause, but generally the rules are you're going to restrict their potassium and phosphorus, and then low sodium diet. Okay. This is where people get confused. This is for chronic renal failure. If we worry about hyponatremia with acute renal failure, why would we restrict sodium? Well, we don't. We restrict sodium in chronic renal failure if they are having a lot of fluid retention. Okay? If you're hyponatremic, you're not going to restrict sodium. In adults, I think these rules are a little more hard and fast. With kids, the reality is if they're on dialysis and they want Doritos, we let them have the Doritos, right? We want the calories in them, and sometimes we just really implement bad practices if that's the only way we can get calories in them. Okay, and we know that with dialysis we're going to be able to pull off those electrolytes that we're putting in them. What's real common is overnight feeds. A lot of the times these kids will have a G tube or an NG tube, and then we will give them supplemental feeds just so they get the extra calories. These kids do not want to eat. Their abdomens are full, they're distended, they just don't want to eat. Okay. All right, any questions about chronic renal failure? Okay. All right, here's a good part. Acute renal failure is just really interesting, and this is, if I put you to sleep, this is the time to wake up. Because with acute renal failure, you need to be able to distinguish the differences between glomerulonephritis, hemolytic uremic syndrome, and nephrotic syndrome. Okay? They all are going to have high BUN and creatinine, but then there are other lab differences and presentation differences that you really need to know. So, you guys probably learned about this in adult, the difference between prerenal, intrinsic renal, and postrenal. Okay? The most common reasons that people go into acute renal failure is prerenal. And like I was saying, you need to have that pressure gradient. Okay? Dehydration, probably the most common reason kids go into acute renal failure. Prolonged resuscitation and shock. Okay? So anything that causes poor perfusion is going to be considered a prerenal cause. So, again, just think about the striated sponge. Renal is if you have damage to that kidney, or if you have chronic renal failure where you've got damage to the kidney. Glomerulonephritis, there's damage to the kidney, so that would be considered an intrinsic renal, or trauma. Okay, or drug overdose. Anything that causes damage to the kidney itself is considered an intrinsic renal or renal cause. And post-renal, real common with kids. If they have any kind of obstructive uropathy, that's going to be a pretty common reason that they have renal failure. So, here's, I don't know if I told you this, anything that's colored means that I've seen it show up in an NCLEX type question, right? So, they want you to be on the lookout for nonspecific symptoms. Usually tachycardia is the first symptom of everything in renal failure. However, nausea, vomiting, lethargy, not wanting to eat, those are early signs. We tell you, Dr. Kubin tells you, don't worry about high blood pressure. This is the time that you need to worry about blood pressure. Okay? We want you to care about blood pressure right now. All right. All right. Back to the sponge. The main thing I want you to worry about, basically with these kids, electrolytes tell you a whole lot. Those of you who want to work in the ER, if you go to the ER, I want you to pay attention to this, okay? We come in, we're going to bolus these kids. You'll learn in the GI lecture, though, we don't bolus them unless they have poor perfusion, okay? So ideally with kids, you'll see orders all the time. Once we have them stabilized, give them D5.5, add 20 of K after first void. So that's something that's pretty standard with kids. We don't add potassium to the IV until we know that they are voiding. So keep an eye out for that if you go to the peds ER. Ideally, you want to be checking these labs frequently. But your classic scenario is they come in, you bolus them, they blow up, and then you're like, uh-oh, we have a renal problem. Okay. My brain just lost a thought. I'm sorry, I'm trying to get it back. I'm so sorry. Hopefully it'll pop back in there. All right. Okay, so we have these kids, we come in, we have bolus them, we're like, uh-oh, we've got a problem here because this kid's blowing up. Check labs. And one thing that we'll do is we'll give them a Lasix challenge. You do this with adults too? You familiar with this concept? Lasix works on what part of the nephron? The tubules, right? Okay. So, in order for Lasix to work, you have to have some sort of function in those renal tubules. Okay? If you're in full-blown renal failure and you give them Lasix, it's not going to work. You have to have some sort of function. So when we're trying to figure out how bad off are we, sometimes we will give them a dose of Lasix and see if that helps perfuse things. And sometimes that's all it takes. Give them a Lasix, it'll kind of help open things up, and then we're back on track. If that little Lasix challenge doesn't work, then we know we're in trouble, and off to the ICU they go. Okay. If they're severely hypovolemic, we will give them albumin. Okay, or if they start blowing up, we'll give them that. I had a really good question come up one semester. A student said, well, why would you give albumin if they are dehydrated? Dehydration and hypovolemia are not the same thing. Okay, I think this is where a lot of students get confused. I never realized it. In dehydration, those cells are all shriveled up and dried up. With hypovolemia, you've got fluid that's not within the blood vessel and it's third spacing. Okay? So, yeah, you would not give albumin if they're dehydrated. It's not going to do any good, right? Because you don't have all that fluid to pull back into the blood vessel. So, hypovolemia and dehydration are not the same thing. Don't get those confused. We would only give albumin if they're symptomatic, if they're edematous. You pull that back in, and hopefully, if you have enough function in the kidney and you can open it up with the Lasix, then they can excrete it. Okay. All right. If their potassium is up, we want to give them K-oxalate. Anyone giving K-oxalate? It's just nasty. It's just nasty. I had to give it at the VA in my adult rotation. I'll just never forget it. It was awful. All right. How are we going to get their calcium up? In chronic failure, we give them Tums. Okay, they're on Tums daily. In acute renal failure, we're not going to give them Tums because, A, they're really sick and they're in the ICU and they may be intubated, right? We can give them calcium gluconate to get that up if we need to. Okay. How are we going to treat the acidosis? Bicarb. Okay. And then here's the deal. If we need to put them on dialysis, the good news is that it's usually temporary. And usually if you tell a parent, we need to put your child on dialysis, they think it's the end, right? It's not. You have to tell them we're just resting the kidneys, and then as soon as they recover, we can take them off. Okay. All right. This is really, really important. I think most of my clinical group, I've adequately scared them with Gent. Okay, you need to be afraid of Gent. You need to be afraid of those nephrotoxic antibiotics. Okay. If you have impaired renal failure and you give Vanc, Gent, Tobra, and their BN and creatinine are high, it can throw them into serious renal failure. The reason this is so important with kids is that you can cause permanent hearing loss. Okay, so you really need to be afraid of these. This is where you would question the order and say, look, are you sure you want them to have this? It shocked me on the renal floor at Children's all the time. They would order these antibiotics, and then they wouldn't order peaks and troughs. I'm like, are you sure you want to do that? And they're like, oh, yeah, maybe we shouldn't. Maybe we should try something else. Okay, it's totally appropriate to question that order, okay, especially with kids. All right. One thing you'll see in the NCLEX books, they'll ask you what are your priorities. Weight management is really, really important. Meticulous skincare, if they're edematous, is really, really important. Turning them frequently, monitoring their labs. Monitoring their blood pressure. Okay. And then monitoring for those neurosymptoms. Now, when kids are in renal failure, what's going to be the first sign of improvement? An increase in urine output, right? That's the first sign, and you'll see this in the NCLEX book. That's the first sign, but the most accurate sign is that daily weight, and you want to do it at the same time every day in the morning without their clothes on, or if they're intubated, you can use the bed scale. Okay. All right. These kids in renal failure, their bodies are working extra hard. They're not taking the calories in, and they're breaking down tissue to compensate, right? So you have to be on the lookout for that, skin breakdown, both from the edema and from being in a catabolic state. And you have to make sure we're getting enough calories in them. When it comes to teaching, usually at discharge, making sure those families know what their dietary restrictions are. And it's going to depend on why they're in renal failure, so it's going to be specific. And then a lot of these kids, they're going to have blood pressure problems for a long time. Okay, so we usually have to teach them how to monitor them at home and making sure they know their medications. Good news is that the prognosis is really good. And then here's a question. What would you not expect to see? This one I wish I had clickers. The answer is B. You'd expect it to be high potassium, hyperkalemia. Okay? Prerenal. C. Glomerulonephritis. Do you learn about glomerulonephritis in adult? Yeah. Okay. All right. Let's talk about it again. All right. All right. Here's the deal. Glomerulonephritis, HUS, nephrotic syndrome. Okay? It's easy to get them confused. I have this presented in a way to help you remember, and it all comes down to the name. When you see glomerulonephritis, the itis should alert you that there's some sort of infectious process. Okay? And then the S, you just want to add strep and put them together and get glomerulonephritis strep. Okay? So when you see glomerulonephritis, I want you to say glomerulonephritis strep. Okay? Say it with me. Glomerulonephritis strep. Okay, and if you can do that, you're going to go down the right path. Okay? The other thing that you see in the NCLEX books is that cola-colored urine is classic for this. What color is my font? It's brown. This is brown. And then in your bag, I want you to take your beautiful, beefy, red, healthy glomerulus and replace it with this brown bead that you have in your bag. Okay? Your brown bead should have a big gaping hole in it. Okay? All right. So, in glomerulonephritis, you're going to be leaking blood and protein. Okay? So that's what that little hole represents. Okay? Now, it's important that you know that glomerulonephritis is usually follows a strep infection. Not always, but most of the time. If you were to culture that kidney, you would not find strep in the kidney. Okay? What happens with glomerulonephritis is your body produces antibodies to that antigen, and that's what attacks the kidney. Okay? So, are we going to give them antibiotics for strep? No. Not Vanc, not Jen. No. Generally, they've already passed the point. If you were to culture their throat and they tested positive, then okay, yes, you're going to treat them, but you're not automatically going to treat these people, right, with antibiotics. That's not the main source of treatment.
I thought they actually put them on a maintenance dose when they have it, like 200 milligrams. The kidney reported things like 200 milligrams or 250 milligrams a day during the treatment process for glomerulonephritis.
Not for kids. No. In fact, the treatment The treatment for glomerulonephritis is watch them most of the time. All right? It's going to gradually resolve on its own, and it usually takes about 6 to 8 weeks. Most of the time, kids are managed at home. We watch them. If they're really symptomatic, then we'll bring them in, and then we watch them a lot more closely. But the main treatment for this is fluid restriction. We're going to rest those kidneys. So this is where that concept of conservation will show up on NCLEX, right? Most of these kids, this came up I saw this in an NCLEX book one time. What's the typical age of kids who get this? It's 6 to 7. I'm like, what a dumb question. It doesn't matter what age they are. You're going to still treat it, right? I'm like, what a dumb question. But anyway, that's why it's somewhere in my slides. The typical age is 6 to 7. So here's the deal. When does the concept of conservation get fully developed? School age, right? So these kids may or may not have that mastered. But what you'll see is the best thing you want to do is give them little medicine cups and spread those out. And the reason you want to do this is you can fill a medicine cup with 30 mLs and they get to drink the whole thing. If you put 30 mLs in a big cup, they think they're just getting a little bit. Okay? And then one of the little tricks with fluid restriction, especially with glomerulonephritis, if they're fluid restricted, you can give them ice chips, right? And ice chips, when they melt, they're going to fill up about half of the medicine cup. So you can give them 2 cups of ice chips, and they last a little bit longer. Okay? All right. Here's the other thing. When you say glomerulonephritis strep, I want you to go, glomerulonephritis strep. All right? Do it with me. Glomerulonephritis strep. Okay. So when I'm in clinical and people say, hey, glomerulonephritis strep, it's usually like this. Okay? And when people take their NCLEX review courses like Kaplan, the TW section always goes, glomerulonephritis strep. So, and Miss Moore, she gets it, but if it's another instructor, they just kind of look at that section, a little goofy. But that's okay. They know their stuff. What does this mean? Why do I have you guys? Yeah, it's to indicate periorbital edema or edema from the neck up and hypertension. All right, so with glomerulonephritis, you've got hypertension. Nephrotic syndrome, you don't. But in real life, you do. But NCLEX land, glomerulonephritis, high blood pressure. So that's going to be one of your priorities, monitoring blood pressure. Okay, and periorbital or facial edema. Okay. Oh, there it is. School age, 6 to 7. All right, symptoms. The reason you have the cola-colored urine is because you've got blood. You don't have frank blood in the urine. You just have enough to turn it brown and icky. And since you have poor urine output, it's concentrated anyway, but it gives it that characteristic icky. Now, anytime you have renal failure, you can have cola-colored urine. It's most commonly associated with glomerulonephritis strep, though. Okay? You're going to have facial edema. You're going to have hypertension. And you can have fever and fatigue. Now, what's really important with this, it shows up in the NCLEX books. I don't know why they make a big deal of it, but basically it's self-limiting. And so this is where toy questions show up all the time. You don't want these kids to be ambulating the hall if they don't feel like it. If they feel like resting, you just let them rest. You keep them on bed rest until they feel better and they start moving around. So, what's the appropriate toy for a school-age kid who's on bed rest? Board games. Okay, coloring books a little bit younger. Why are board games better? Because it's with a peer. All right? Okay. There's something wrong with coloring books, but board games is better because technically it's with a peer. All right? I saw an NCLEX question that said, you have a kid with glomerulonephritis, and they're playing a board game. Who's the best person to play? And it's the mom, the nurse, the younger sibling, or a friend. Friend. How many friends have you seen in clinical? Yeah, not many. It's usually mom, right? But in NCLEX land, the right answer would be the friend because of growth and development. Okay? All right. Kind of like the whole, in clinical, everyone's watching TV, but it's always the wrong answer. Right? Okay. Kind of the same line. All right, so when you draw labs, you're going to do your BUN and creatinine, right? You're going to do a CBC. They may be mildly anemic, right? And their albumin may be a little bit low. But the hallmark lab for these is a positive ASO titer. The positive ASO titer isn't going to show positive for about 10 to 14 days after an exposure to strep. Okay, so even if it's negative, classic question is, what questions would you ask someone who walks in the ER? You ask, have you had a sore throat? Okay. All right, how do we treat them? We fluid restrict, we may give them a diuretic, may or may not. This is the case. This one is a case where we would restrict sodium unless they're hyponatremic, but generally, since we're fluid restricting, they're not going to be at risk for hyponatremia, right? Hyponatremia comes from the hemodilution. So the main reason we would restrict their sodium is because the high blood pressure. Okay. What hypertensive are they going to be on? Right, like the prils, enalapril, captopril. So if they don't work, then we start adding other ones on. So but the frontline therapy is going to be enalapril or captopril. If that doesn't work, we may add a calcium channel blocker or beta blocker. Enalapril or captopril? Okay, I'm not sure which one I said first. Okay. Nothing new on that slide. Okay. All right. Oh, when they go home, we give them urine dipsticks. We teach them to continue dipping their urine at home. It's going to take weeks for it to go away. Okay. All right. I got ahead of myself. What do we teach them? Yes, they're going to dip their urine. We're going to teach them how to take blood pressure. What's that? Like a little dipstick, right? So they're going to have blood and protein in it, and then over time it's going to decrease. Okay.
Yeah, it has little strips, a little white stick that has these little sponges on them, and then we can dip it in. It tells you how much protein or...
Do you not do that in clinical? You don't do that anymore? You know, it's interesting. In the dirty utility room, like for decades, we would have all that stuff in the dirty utility room, and we would go in and dip the urine. But now that you mention that, we don't do that anymore. Did you? Okay. Yeah. We do that on hemoc, like we'll have it in the kids' bathroom. We dip it so that we know the specific gravity is low enough to give the chemo, and that if they're on Cytoxan, right, that they're not having microscopic bleeding. Okay. So, yeah, I really had never thought about that, but we don't dip urine in clinical like we used to. Okay. All right, what's the first sign of improvement? D, urine output is going to increase. Okay. It's going to take a while for that blood pressure to return to baseline. Okay. All right, so I'm so excited. I found Krabby Patties candy this year. So, but I bought every bag that the CVS had, but I didn't have enough to put in all of them, and I wanted to save some for next semester. So some of you have Krabby Patties, some of them don't. So what I want you to be able to do with this, when you study, I want you to be able to take all these objects out and explain to a friend or your dog or anyone who will listen to you what these are for. This is the best way to study. If you can explain what that Krabby Patty is for, you'll go down the right track. So, when you see the word hemolytic, you should be thinking bleeding, right? You think blood, all right? Uremic, you should be thinking urine, renal failure. But when you see this word hemolytic, I want you to think blood, and then I want you to think blood and guts, okay? So again, all the tricks to remembering the little differences are in the name. So hemolytic uremic syndrome, think blood and guts. All right, there's a little hamburger. This is the main culprit, all right? This little nasty hamburger is undercooked. Yep, except it's all red inside, all right? So it's going to give you E. coli poisoning or Salmonella, Shigella. So those are the main things that are going to cause hemolytic uremic syndrome. E. coli, Shigella, Salmonella, any of those nasty organisms that causes bloody diarrhea, all right? So the blood and guts, blood is for hemolytic, the guts is for this, E. coli, Salmonella, or Shigella. So in your bag, you should have a little sparkly ball, okay? All right? So what happens, okay, so what happens, that E. coli, Salmonella, or Shigella releases a virotoxin, okay? I love this slide, all right? But that virotoxin, even though it's really pretty, it's pretty nasty, okay? And so I'm going to pick up your kidney, and this nasty virotoxin is going to scratch the kidney, okay? And it's going to cause it to bleed, all right? So you're going to have lots of bleeding. How's your body going to respond? What's going to repair those little bleeds? Your platelets, all right? So your platelets are going to rush to the site and save the day, all right? Okay. So if all those platelets are rushing to the site to save the kidney, what's going to happen to your serum blood count? It's going to be low, and it's going to drop really, really fast. And this is the main thing you need to know about hemolytic uremic syndrome. You're more likely to have marked anemia, whereas with glomerulonephritis, you're going to have mild anemia. But here, you've got significant bleeding, and your platelets are going to be low. And this happens really, really, really fast, okay? This happens really fast. And so if you're not paying attention, you're working in, you know, a little ER in South Dakota in the middle of nowhere. And if you're not on it and you just kind of, let's wait and see instead of shipping to a tertiary care center, this kid is not going to make it. The mortality rate for HUS, if it's not treated appropriately and rapidly, is pretty high, okay? So when you hear on the news about this kid died from E. coli poisoning from eating spinach, it's actually hemolytic uremic syndrome that's going to cause this. And the most common age for this is preschool kids. Toddlers and preschoolers, so it hits younger kids, right? The kidney just doesn't have as much reserve, okay? All right. So, think back to the hem-onc lecture. If you have all this bleeding, how's your bone marrow going to respond? It's going to start shooting out what? Immature red blood cells, right? Anytime you have a hemolytic process, your body is going to start shooting out immature red blood cells, which are reticulocytes. So your retic count is going to be high. Okay. All right. You're going to be leaking protein as well. You'll see this term schistocytes. It's just, you'll see that written on the peripheral smear. We'll see that in clinical sometimes. It'll just be like a little note, schistocytes noticed on peripheral smear. And then you're going to have all the signs that you have with thrombocytopenia. All right. So let me hold on. I'm going to read a note to you. Hold on. Okay. So, chief complaint, bloody diarrhea, elevated BUN and creatinine, decreased urine output, metabolic acidosis. This taken from a chart. I'm reading a chart to you. So, chief complaints, bloody diarrhea, elevated BUN and creatinine, decreased urine output, metabolic acidosis. Okay? Classic. So let me tell you what happened. This patient is a 4-year-old who was transferred from the pediatric floor to the ICU urgently tonight due to the above chief complaints. According to her mother, she had been in her usual state of health until a week prior to this admission when she developed some diarrhea. Because she did not get better, mother took her to the pediatrician. He did the stool culture and sent home with instructions to treat the diarrhea at home. Because the diarrhea continued, she was taken to the emergency room. She was sent home after some fluid bolus was given, IV, to treat her dehydration. Okay? Classic. That's what we do. Kids come in dehydrated all the time. We bolus them. On Monday, the mother took her back to the emergency room because she did not feel well, and the stool test at the doctor's office was back with E. coli, Shiga toxin positive. She was subsequently admitted to the pediatric floor with mild metabolic acidosis with signs of moderate dehydration consistent with a BUN 26 and a creatinine of 1.6. So not horrible. Okay? So she was admitted to the pediatric floor. She has developed bloody stools multiple times, and subsequent electrolytes have shown worsening acidosis, along with fast-climbing BUN and creatinine. Her urine output has dropped. Her hemoglobin, hematocrit, and platelet count was started with a normal range of 13.6 and platelets 274,000. Since admission, and we're talking in a 6-hour period, her hemoglobin dropped to 10, so 13.6 to 10. That's a fast drop in 6 hours. And her platelet count went from 274 to 36. Okay? You got to know what you're doing. This is why you have to be thinking strategically for those clues. When kids come in dehydrated, poor urine output, you've got to be ordering the right test, and you've got to do it fast. Okay? Let's see. Her electrolytes have also continued to have gotten worse, with the sodium dropped to 132, potassium 4.2, so not horrible. And her creatinine jumped. Let's see. It was originally 1.6. It went up to 2.93. All right. Her BUN ended up going up into the 80s within 24 hours. Creatinine went up to 5.8. Hemoglobin dropped to 6. It was all within a 24-hour period. And her potassium went up to 7. Okay, train wreck. All right, off to the ICU. All right, so we're going to treat all those things. Yeah, so because of the worsening electrolytes, hemoglobin, and platelet count, she was transferred to the ICU emergently and started on dialysis. Okay, so there you go. That's hemolytic uremic syndrome, classic. When I saw that note in clinical, I was like, oh, I'm stealing that chart. So, She survived. She did. But what's fascinating is when you pull up the charts, and I do have her labs here, you can see the classic started on dialysis, lots of transfusions. She would go up after her transfusions, but then she would drop rapidly again, right? She wasn't able to sustain them. It takes a while to maintain this. Yeah?
What kind of interventions earlier on in that process would have is there a way to prevent her from having to go on dialysis, or would getting her on dialysis sooner?
Well, it happened in a matter of 6 hours, right?
If they treated with an antibiotic, though, wouldn't it have been, don't they treat the Shigella with?
It's probably not going to make that big of a difference, though. I mean, they need to rest those kidneys. So can you prevent them being on dialysis? Probably not, because it happens so fast they're acutely ill. The problem comes in if you're not paying attention and you're just watching them. By the time they need dialysis, if you're at a small community hospital, by the time you get them transferred, it can be too late. So, what's that?
Dialysis as soon as possible.
As soon as possible. Mm-hmm. But you don't want to put them on if they don't need it. Like, there was no indication that she should have been put on dialysis from the get-go. You just have to be paying attention, right?
One question, how would they, was there something that could have been done, like, at the doctor's office, like if they had caught something before, you know how they sent her home, and just monitor, like, treat diarrhea, and then she went back, and then sent home, like, was there something, an intervention that could have been done prior to the last position?
Maybe, but they didn't. She had diarrhea, but it wasn't bloody diarrhea, and it looks like it took a while for the culture to come back. Like, the culture is not going to come back right away. But if you think about it, it's kind of like with leukemia. How many kids come into the doctor's office with malaise and fever, right? And how often do you see hemolytic uremic syndrome? Not a whole lot. I mean, I see it just about every semester, but not a lot. It's not common. It's like one of those, like, I get excited when I see it, just because it's fun to look at labs and say, look, it does happen. But it all comes back to that CBC. If you're not thinking, well, I'll just do electrolytes, see what the BUN and creatinine are and see what the lights are, you're going to miss it.
So I guess there wasn't really a question that the doctors could have asked that would have maybe
No, I mean, this is rare. If you think how many kids have diarrhea, and it didn't start out bloody diarrhea, right? And this was a matter of 6 hours. Yeah, so it was when the labs dropped rapidly. Right. It's all the pieces, putting all the pieces of the puzzle together, but it was the rapidly dropping labs. And it's just like, you have to look at all of these things at once. So when people come in, like in the ER, when people go to the ER in clinical, one semester someone came out from the ER, I'm like, oh, it was boring. All that happened was a kid came in with a swollen face. And I was like, what labs do they draw? I got really excited. And the student was like, what? This was actually when the Ebola thing was going on, and we had transferred a kid from one ER to Medical Cities ER, was suspected that. So everyone was all excited about Ebola, and then all of a sudden this kid comes in with a swollen face. And so no one thought that was any big deal, but I wanted to know more. I wanted to know what labs they drew, because what does a swollen face tell you? Glomerulonephritis. Do we want to check a blood pressure? Yes. Is it going to be high? Are we going to bolus them? No. We're not going to bolus them. No. Who said yes? No. No. Okay. All right. Let's see. Did I talk about all this? Okay. All right. For NCLEX, what you need to teach them, of course, this is, a little late, but when they go home, teach them to cook their meats well. All right. Another common place that you can get an E. coli infection is from petting zoos, right? So you're not going to deny them from going to the petting zoo. You just tell them wash their hands really well afterwards. So I told you the main, for NCLEX, okay, glomerulonephritis is when it has high blood pressure, but I will tell you all of these kids end up on ACE inhibitors, right? So if they are hypertensive, they go home on one, you have to teach them how to use the meds, and then you have to show them signs of recurrence. Now, with hemolytic uremic syndrome, it's usually a one-time deal. It doesn't recur, okay? But just in case. All right. Anyone? D. You're expecting to see an increased retic count. Oops. Okay. I am going to talk about nephrotic syndrome, and then we'll take a break. Okay. All right. When you see nephrotic syndrome, I want you to think nephropathy syndrome. Okay. This is another thing that will stick with you throughout your career. Nephropathy syndrome. Now, I teach this backwards. All right. We'll get back to the cause, but let's start. Why is your urine frothy? Because you're leaking protein. So I want you to think nephropathy syndrome, it's frothy because you're spilling all that protein. If all that protein is in your urine, do you have any in your blood? No. Right, so you're going to have really low albumin, serum albumin, okay? And because of that, you're going to have massive third spacing, right? So when you say nephropathy syndrome, I want you to think nephropathy syndrome, like edematous nephropathy syndrome. Okay.
Does that mean that we're also, I guess, hypovolemic?
You're hypovolemic, yes. So this is one where you would probably want to be giving albumin and Lasix. Okay. Now, what was confusing when I was learning this in nursing school, I'm like, okay, if albumin is a water magnet, right, then if you're losing all your urine, then if you're losing protein in your urine, why isn't the water following that magnet, right? The reason for that, the way I kept it straight in my head. You think of it like a superhero. This albumin is a superhero. It has that little magic cape on where it keeps all the blood in the vessel. But once it loses that, once it leaves the blood vessel and enters into the kidney, it loses its cape. It leaves its cape trapped in the glomerulus. Okay? Right? I know. If it helps you get a question right, okay, but just that's how it kept it in my mind. It only has those special powers inside the blood vessel. Okay? That is confusing. All right. Why? Because the glomerulus filters out the magic cape. Okay? That's why. Okay? That is why. All right. So, ballerina, a peer tutor, that's how she remembered, like, just think of generalized edema. Now, what you need to know for NCLEX is that your blood pressure is low with this, but, all right, here's in my clinical group. We had a kid with nephrotic syndrome. What meds was he on? Who had him? Anyway, this kid was on, I think, enalapril, right? Who was that? Sorry. What's that? Okay. But here's the deal. Well, in general, hold on. I'm going to come back to that. Let me finish my train of thought. Okay. So, frothy urine, it's frothy because you have all this protein in your urine, so you don't have any in your blood, so you're third spacing. How does your liver respond? It responds by releasing or producing cholesterol, all right? So your cholesterol is going to go up. It's just one of those random things. There are different theories as to why it happens, but just think your body responds by shooting out cholesterol. It's not going to do that with the others, okay? So this is your hallmark lab for nephrotic syndrome. Your cholesterol is going to be high. Your albumin is going to be low. Okay, so why does this happen? It goes back to that little brown bead. I lost my bead. Okay, it becomes leaky. There it is. With nephrotic syndrome, it becomes leaky to protein massively. What's really interesting, though, I don't know if you learned this in adult, but the other name for nephrotic syndrome is minimal change disease. Have you heard that term? Okay. Minimal change disease is it's a form of nephrotic syndrome, and the reason it has that name is that if you were to look at this glomerulus under a microscope, it would look normal. There's no minimal change, there's no massive change, but under a special microscope, you can see that it's leaking the protein. Okay, so it's not like you can really look at the kidney and say, oh, that's going on. You have to look at it under a certain microscope. So here's a picture of that. Minimal change disease, you'll probably see that in the NCLEX books. Just think of it as a more mild but the most common form of nephrotic syndrome. So what happens, this is a normal glomerulus, and see how it keeps the protein in there inside the mesh panty, right? Okay. And minimal change disease, it's basically, this mesh panty isn't really changing that much, so in order for that protein to get out, it has to go through a lot of pressure, which is going to make that big splash in the bladder. Okay? Does that make sense? You're not buying it. Just think, it's a heavy molecule. It's not like it's just, okay, it's not coming out of the legs, right? This big hole where it's just going to come through. It has to fight to get out, right? Which means there's a lot of pressure behind it, which is why it makes a big splash and makes your urine frothy. Did the light bulb go on? Okay, good. What's that?
When she said frothy.
Yeah.
Okay, that's why it's frothy. See?
When you pour a beer, and it has a froth, the urine looks like that, kind of. I mean, not that frothy, but it bubbles up quite a bit.
Mm-hmm. Kind of looks like that. Okay. Yeah. Never had that happen. Sure. Maybe. Okay, okay. So what causes this change to happen? What causes this? No, it's not damage to the kidney. It's autoimmune. Okay, it's autoimmune. So, here's your frothy urine. Okay. Your LDL, your cholesterol is going to be high, your albumin is going to be low, severe edema all over. Okay. Here's your mush panty right there. Okay. And so how are we going to treat it? Since it's caused by an autoimmune process, we're going to treat it with steroids. Usually give them like a solumedrol pulses. Okay. All right, we're almost ready for break. All right, so here's what you're going to see. I've talked about all of these things. Classic presentation, when they wake up, they may just have facial edema, but throughout the day it's going to get gradually more dependent. All right. This is one of those presentations where you really want to check the scrotum. If you have massive scrotal swelling, you want to make sure you elevate the scrotum and put them on ice, right, so it doesn't damage the testes. Okay. Right. So that's one of your assessment priorities. Okay. Dark frothy urine. If they're massively edematous, they're going to have that pale, shiny skin, and you want to turn them frequently. You need to remember this for NCLEX. Their blood pressure is usually normal or low, but in the real world, they're actually usually hypertensive. Now, back to this other kid. Since it's autoimmune, this is something that can recur. This can become a chronic condition. It doesn't always turn out that way, but it's not uncommon for these kids to end up on steroids for a long time, right? Because it can constantly recur. So in education, you have to constantly stress the importance of catching the frothy urine, the protein, the relapses early. So these kids, you want to check the urine for protein and blood frequently, checking their blood pressure. So if you have a chronic condition, if you do have progressive damage to that kidney, yes, you're more likely to see these kids on blood pressure meds, where with the first presentation, not so much. Okay, so we're going to give them steroids. So everything you've learned about steroids, you need to apply here. Okay, everything from not giving them too much fluid to, managing blood sugar, yada, yada, yada. Okay, this one is if they're massively edematous, you don't want to give them added salt. And the protein diet is going to vary. If you let them eat a lot more protein to replace the protein that they're losing, they're probably just going to lose it anyway. So we don't really limit or encourage protein in the diet. Okay? And if they're severely hypovolemic and symptomatic, we're going to give them albumin and Lasix. Okay? This typical. Oh, because these kids are treated with steroids, same thing as oncology. They're going to be immunocompromised, so you need to be afraid of chicken pox. If they get exposed to chicken pox, you need to bring them in and give them VZIG. You don't just kind of wait and see. And you want to avoid the live vaccines, which are what? Flu mist, MMR, varicella. You need to know those, okay? All right. These questions, then we're going to take a break. Yeah. When are you going to see a positive ASO titer? Glomerulonephritis strep? Okay. All right. Let's take a short break. Yeah. We should be done by 10:15 today. So let's take a 5-10 minute break. Online. That shows the procedure. There are different ways you can repair it, but they were just pretty gross. So I'm not going to show them. Here's what you need to know. Okay? These kiddos have an increased incidence of testicular cancer and infertility. Even if you repair, okay, so the problem with cryptorchidism is that the testes, in order to produce sperm effectively, they need to be at a lower temperature, right? So if they're up in the inguinal canal or the abdominal cavity, you're going to toast the testes, all right? Miss Trinka taught me that. Toast the testes. You don't want to toast the testes, right? So once you bring them down, that hopefully decreases the risk for infertility. But it does, even if you do repair the cryptorchidism, they still are at an increased risk for testicular cancer, so they need to have extra screening. Okay, that's really important that parents are taught that. They also have a higher incidence of testicular torsion, where the testes will twist on itself. Every time I see testicular torsion, I think of an old nurse, Betty, who, when I was a new grad, she came to the nurse's station just horrified. She's like, I can't believe I just did this, but she had a kid with testicular torsion, and he had a repair, and she went in and she lifted the covers back and said, here, put an ice pack on and said, this is going to make you feel much better. Put the covers back and left, and then she realized that was her TNA repair, not her testicular torsion patient. So she said his eyes bugged out, and she's like, well, what's his problem? And then she realized, oh, wait, that's not my testicular torsion, but my TNA kid. So, yeah, I just always think of Betty when I see testicular torsion. So, okay. So, cryptorchidism is actually a very common condition. I think it's maybe 1% of the population, and it's very, very common in preemies. Okay? The good news is that they usually descend on their own within that first year. If they don't descend on their own within the first year, that's when we start treating them. And the two main options, we can either give them hormones or we can do surgery. Okay? All right. This is something we look for at birth. I don't know if you were able to do a newborn assessment, but that's one thing that we always look for on the newborn assessment. It's not uncommon for the testes to retract when the infant's crying or upset, so you always want to do this in a warm room, or ideally with a neonate under the warmer. Okay. All right. So we can give them either HCG or luteinizing hormone, the nasal spray. If that doesn't work, then we go to surgery. But some people just skip the hormone treatment and we'll go straight to surgery. Okay. All right, so the surgical procedure is orchiopexy. Two major ways we do it. The old traditional way, they would pull the testes down, and then they would suture the scrotum to the thigh for about a week. Anna got to see this procedure done, and they put buttons, right? Were the buttons on the outside of the scrotum? Okay, so they put buttons, and they kind of suture them down. The buttons hold it in place, and then do you know how long before they remove? About a week. Okay. Yeah, cool. In PD, are the buttons pretty colors? No? Okay. They should. They should. Okay. All right. So, main thing you need to know, very common in preemies, they'll usually descend on their own within the first year. If they don't, hormones, that doesn't work, then orchiopexy. What you need to know about just GU surgeries in general is that you want to have these repaired before they're potty trained, if possible. Okay. Couple reasons for that. You don't want to go backwards. Once they've potty trained, this is going to cause setbacks. Okay. And then the whole mutilation. The older these kids are, the more they're worried about mutilation. So earlier, the better. But you also, you don't want to do this on a preemie. You want to make sure that basically the bigger things are, the easier it is to fix, right? Okay. Hypospadias. All right, you have a little worm, little gummy worm, okay, in your bag, and you should have a little toothpick. Okay? So, these actually have, oh, you know what? shoot. In your renal bags, you have the cola, these little cola. I didn't talk about those, but in the bag, that cola-colored urine goes with which disease process? Which is it most commonly associated with? Glomerulonephritis, strep. Okay. So, all right, with hypospadias, the urethral opening should be right in the center, okay? Right? With hypospadias, it's usually on, well, it is on the underside, which is also the ventral side, okay? And I remember in nursing school, how do you remember it's like ventral is on the underside? So, to help me remember it, I combined hypo with vent. You get hypovent, like hyperventilation, okay? So that's how I remembered. All right, you can laugh at me, that's okay. If it helps you get a question around an NCLEX, I'm okay. I'm okay with that. So hypoventral, hypovent, okay? So how do we treat this? Surgery. What you need to know for NCLEX is that you do not circumcise these kids, all right? And the reason for that is you can have the urethral opening that's distal, which is going to be easy to repair, but it can be anywhere along the shaft. And so if you have the urethral opening proximal, you're going to need multiple surgeries to repair that. If it's distal, not so difficult to repair, but it takes reconstructive surgery if it's a proximal defect, okay? So you're going to need that foreskin for reconstructive surgery. So you want to preserve that tissue. And I'll show you why. I have a beautiful video, okay? Yeah, but see how, it can be all the way down here by the scrotum, okay? So, hold on. I'm going to show you a video to help you understand why you don't circumcise. And just, all right, how do I get the volume up? Okay, I guess we don't need sound. It's just a model, guys. It's not real. Notice it's not bleeding when he cuts into it. I know. It's always interesting watching the guys' faces. It's latex, guys. Otherwise it would be bleeding. It's not real. You can have nightmares. This is why you don't show this at bedtime, okay? You're rerouting. Easier said than done because it's not just the opening, it's the whole urethra, right? So, what's that? Well, it becomes problematic. Yeah. Infection, fertility. Think about potty training. If you have a real proximal opening, that's going to be problematic. Yeah, it's so they leave that stent in. Okay, all right. Hopefully that won't cause PTSD for you guys. Okay, it was just a latex model. It wasn't real. It's make believe. It's just make believe. Yeah, but. Hopefully now you remember you don't want to circumcise at birth. You want to wait, okay? So you'll see this repaired usually before the second birthday. Same reasons with the cryptorchidism. But yeah, you do want to repair it. Now, the complications you can have, that little stent that they had in there, that's going to stay in for a while. When that's ready to come out, one of the complications you can have is strictures, where, you know, that tissue just doesn't want to stay open. So that's a problem. One of the complications you need to worry about. But essentially, anytime you have GU surgery, you run the risk of having spasms. That's really common. And you're going to have, they're going to come back from the OR essentially with bloody urine. Okay? And it's going to stay bloody for a day or two, and you're going to see it transition from cherry red, which is normal initially, to more orange to yellow, yada, yada, yada. It should gradually be nice, clear yellow. It becomes problematic if all of a sudden it turns orange again or pink. Then you need to call. Okay? Anytime you have diversional surgery like this, you can see how traumatic it can be, how your body's going to respond. You can have spasms. So anytime you do repairs, you will often see them on an antispasmodic, especially if it's anything related to the bladder or the ureters. Okay. Now, for NCLEX, what we need about hypospadias, this is what we call double diapering technique. So you have the stent that's coming out, okay? The reason we double diaper is you've got this stent that's coming out so you can monitor urine output and that you can assess it, or they may have a Foley, okay? The reason we do double diapering is that when they stool, you want to keep this area as clean as possible, and you don't want this mixing with the urine, because if they stool and it travels up here, you can end up with E. coli in the bladder, okay? So this is why we double diaper. So all the stool is going to go in the first diaper, and you still run the risk of this the stool getting right near the meatus, but at least it's not going to travel up the stent, okay? So that's what double diapering is about. Okay. The other thing with any of these surgeries, you don't want to put this kid on your hip. You know, moms love to carry these toddlers around on their hip. You don't want to do that because that can dislodge that stent. All right. The other thing, no riding toys. So, what are some riding toys? Think of those little, yeah, like a little tricycle and those little, anything that they straddle. You don't want them straddling anything. Or a stick horse, you know, where they're galloping around on a stick horse. Of course, you don't see those much anymore. But just think you don't want to put anything that's going to cause pressure on that. Okay? Sponge baths only, you don't want them sitting in a bathtub where bath water can get into that stent. Okay. And you don't want them to get dehydrated. The more they can flush things in that direction, the better. Okay? And they'll usually end up on antibiotics. Any questions on hypospadias? That's one of those NCLEX things you just need to know. Those are the key points. Epispadias, okay, back to our little uremic frost. Okay. Epispadias, it's on the dorsal side. So, again, with my little pea brain, epi combined with dor, epidor, like epidural. Okay. So, now, epispadias rarely occurs on its own. It's usually combined with extrophy of the bladder, and that's when the bladder is born on the outside and it's inverted. So it's not like this nice little bladder hanging out. It's a bladder that's turned inside out. So I've got a picture of that right there. Okay. So this you need to know about for NCLEX. At birth, you want to cover this with a sterile saran wrap dressing to keep it moist. It's usually repaired. The initial repair is within the first day or two. Okay. You don't want to put Vaseline on it. You just want to cover it with a sterile wrap. Okay, and repair it as soon as possible. Anytime you have things like gastroschisis, things are born on the outside that are supposed to be on the inside, you can lose a lot of body heat. So you want to make sure these babies remain on a radiant warmer because it's hard for them to maintain their heat. Now with extrophy of the bladder, usually they have some deformities in the pelvis as well. Sometimes it'll be combined with spina bifida. Has anyone seen this? It's Scottish Rite. It's not uncommon at all for them to need multiple surgeries, but that's one thing we look for. We look for a dimple in the back, and then usually they have to have multiple surgeries on their pelvis. Okay, so main thing you need to know about this: at birth, cover it with sterile saran wrap, a moist sterile saran wrap dressing, and then keep them warm. Okay. This is a long road for these guys. All right, multiple surgeries, both, you know, with the ortho piece as well as the bladder piece. Okay. All right. Now we're moving into boring territory, but stuff you need to know. If you need a urine culture from an infant or a toddler who's not potty trained, what's the best way to get it? If you need a urine culture, it needs to be sterile, right? So you want to do an in and out cath. The other way we can collect urine is with a urine bag, and I've got a picture, but you run into risk of contamination. So even if this does grow something out, you're never going to know if it's a contaminant and if that baby needs to be on antibiotics or not. And you don't want these kiddos on antibiotics if they don't need to. The reason I put this picture in here is you can see people think, oh, an in and out cath is way too traumatic for a baby. You don't want to put them through that trauma. But you know what? They don't like this any better than they like being cathed. And this bag has to stay on until you can get a good specimen, which can be a long time, and it can cause damage to the... Yeah, you should. Yeah. Question was, should you have gloves on? And the answer is yes. Okay. But what happens with this, urine leaks all the time. If you're not looking for it and you leave it on too long, it's all going to leak out. It's just collecting urine this way is a pain. If you need a urine culture, in and out cath. Okay? If they're potty trained and they can give you a clean catch urine, that's totally appropriate if you need a urine culture. But someone who can't give you a clean catch specimen, just do an in and out cath. Okay? The other thing you can do is a suprapubic catheterization. You see this at the vet with cats and dogs all the time. You just take a large bore needle and go right into the bladder this way, but high risk of infection and then chance of you nicking the vasculature. So not the best method, and that's usually done by nurse practitioners, not by us. Okay? All right. These are just random facts that I found in an NCLEX book. Normal pH, 4.6 to 8. Why you needed to know that, I'm not really sure, but it was in a book. Now, if you do a urine, let's just do like a regular UA, and you have leukocyte esterase or nitrates in it, that indicates infection. Also, if it's cloudy or foul smelling, that also indicates a urine culture, or a UTI. So if you have these and just a urine dipstick or a UA, then you would want to follow up with the urine culture. Okay? All right. Creatinine clearance. Creatinine clearance is the best indicator of kidney function. It essentially tells you what percentage of that kidney is functioning. So if you have someone with renal failure and you want to know, are they rejecting the kidney if they're a transplant, or, you know, how bad is our renal function? Are we getting worse? You'd want to do a creatinine clearance. Now, it's a 24-hour urine collection, and there's this formula where you compare the serum creatinine with the creatinine that's in this 24-hour urine collection. With an adult, a 24-hour urine collection takes 24 hours. In kids, it takes about 5 days to get a 24-hour urine collection, because if they miss the potty, you have to start all over. A lot of things can go wrong with the 24-hour urine collection with kids. A lot of times they'll get stool in the hat. They can't keep them separate. So just know that a 24-hour urine collection is a challenge with kids. Adults, this is when people will say, I'm going to go work with adults. Okay. All right, diagnostic tests. You have to be careful with giving them contrast. With a CT scan, you usually look at IV contrast. If they're already renally impaired, and then you go ahead and give them dye for one of these, you can throw them right into full-blown failure. Okay, the most common one we see with kids is called a VCUG. With the VCG, it can be pretty traumatic. What we do here, we send them down to radiology. We put in a catheter, and we inject dye into the bladder through the Foley. Okay? Then they hang out on this table, and then we tell them to pee. Okay? And they have to pee on the table, which is really, really traumatic, right? Because actually, once you put the Foley in, or you put the Foley in, you inject the dye, you pull the Foley out. Okay? Now, here is the best I've been able to come up with my renal system. Okay? So, here's my bladder. Here's my short little urethra because it's a girl. Here are my little ureters and my kidneys. Okay? So, normally, when you pee, this bladder will contract, right? And these little openings where urine enters the ureter, there's like this little flap that'll close. Okay? In reflux, that doesn't happen. Okay? So what happens when you pee, you get a retrograde flow of urine up the ureters. Okay? And that's really what we're looking for with the VCUG. VCUGs are common if you have recurrent UTIs. You want to know if you have reflux. The main reason you end up with UTIs is urinary stasis, where you have an inability to completely empty the bladder, and so you have urine that's just hanging out there. Okay. So, in this case, we filled the bladder with dye, they peed, and when they peed, you can see the dye traveled up both sides. Okay? All right. That's a pretty extreme case. It can be bilateral or just one side. But essentially, when urine leaves the kidney, it travels down the ureters using peristalsis, right? Okay? So you have that musculature. With reflux, you've got this retrograde, which over time messes up that mechanism with the peristalsis, right? And so you lose that mechanism, and then the ureters get dilated. Okay? So then it just gradually gets worse and worse and worse, and they're different grades. I've got a interesting video to show about that. But that's what a VCUG is. This is a good time to get your doll out and show them what's going to happen. There was one time in clinical, the charge nurse said, "Hey, we've got a kiddo going down for a VCUG. Do you want to send some students down?" I'm like, "Sure." So the kid, he grabs the student's hands. He's as happy as can be, swinging the hands, and off they get on the elevator. I'm like, did no one tell him what's going to happen? So it came back a mess. Like, this is one of those cases you want to call child life. Okay. All right, obstructive uropathy. So obstructive uropathy, a number of things can go wrong anywhere along the track. Okay. So UPJ, the ureteropelvic junction, you can have a stricture here. This can be diagnosed in utero, and this is one of the surgeries that they can repair in utero, which is kind of cool. All right? You can have a stricture here. Okay? And then you can have with boys, so we'll make this a boy, right? Because posterior urethral valves only happens in males. But basically, you end up with valves inside the urethra, which prevents urine from getting out of the bladder. And this occurs in utero. And what's really interesting, in utero, I think, it's pretty early on that the fetus produces urine, right? And so basically, throughout pregnancy, the fetus will ingest the urine and then they pee it out, and it just gets circulated. Do you remember learning about oligo last semester? Back, remember that? Okay. This is one of those conditions where you can end up with oligo, and I'll show you a picture. Okay. So this is an infant with posterior urethral valve, so he cannot pee because he's got this stricture within ureter. So this bladder just fills up and fills up and fills up. It's a pretty phenomenal picture. This is all bladder right there. Okay? And so what happens, it can only fill up so much before it backs up here, and so all that fluid ends up on the kidney, which is hydronephrosis. Hydronephrosis occurs from a backup in the system, right? It's not a primary diagnosis, it's always as a result of something. So hydronephrosis means something's causing it, okay? Do you guys have a question? No? Okay. Yeah, it's pretty impressive, that picture. So going back up here, let's see, where was I? All right. There aren't any questions on that, but you do need to know vesicoureteral reflux, and so this little dramatic.
Designed for urethral reflux. Designed for urethral reflux is a condition where urine flows backwards from the bladder to the kidney through one or both ureters. Grade 1, urine flows back into the ureter only. Grade 2, urine flows back into the ureter and renal pelvis. Grade 3, the ureter and pelvis appear minorly dilated. Grade 4, the ureter and pelvis appear moderately dilated. Grade 5, the pelvis is severely dilated and the ureter appears damaged.
Okay. Oops. Sorry, I end up with multiple versions up here. Okay, so that's reflux. So what do you do about reflux? Actually, here's some pictures. See how severe that is? Okay. All right. So here's the deal. The problem is that this little juncture right here doesn't get closed off by that flap when the kid pees. So there are a couple things you can do. You can reroute it, or you can inject a substance in here that kind of fills that space, so it makes it harder for urine to get back up there. Okay, so two options, either surgery or those injections. The injections actually work pretty well. Okay, so urinary diversion. You can picture this inside the body. There are a number of things you can do if you have a stricture. So if you have a stricture right here, what you can do is you can detach the ureter. You can put a little stent that goes to the outside of the body, and urine is going to drain into a little ostomy. Okay? You can do the same thing with this junction where you can disconnect here. All right? And I've got some pictures to show you here. Okay. Okay. That's what these kiddos look like. Can you see these okay? So, you can see the ureterostomy where you are going to disconnect. I wish I could disconnect these. From here, you're going to reroute the opening to here where they either dribble into like an ostomy bag, like here, or just into a diaper. Okay? Here you've got the stoma that's a little prolapsed. Okay? Here, you can put a little tube, a little stent to help it drain. Okay, here it's hard to see, but this is a vesicostomy, and it's really just an opening that drains urine out of the bladder into a diaper. Okay? You also have what's called an appendicovesicostomy. Okay? So with this, urine just dribbles out. With an appendicovesicostomy, they make a new bladder out of bowel, and bowel has muscle tissue. So if you have a bladder made out of bowel, they're continent. All right, it's not just going to dribble out. That muscle tone keeps the urine from just dribbling out, and then you'll in and out cath them. Have you seen that at Scottish Rite, an appendicovesicostomy? No? What's that? At the VA. So they just in and out cast. Mm-hmm. Here's another one that's prolapsed. Oh, there you are. Hi. Hi, Amber. They do. No, they need to in and out cath because it's usually a little bit higher, right? So you that urine that's at the bottom of the bladder, it's not, yeah. No, you have to in and out cath. Yeah. I'll just, yeah. Okay, so with these high diversional conduits, this is how you have to diaper them. All right. Okay, isn't it cute? All right, this is a peritoneal dialysis catheter. This is a hemodialysis catheter. Looks like a central line. Okay. This is also a PD catheter. He's hooked up to dialysis. This kiddo too. Here's a little G button. And here's a neonate on dialysis. Okay, this next guy, he's got prune belly syndrome. You used to see this at Children's a lot on the renal floor. These kids don't have abdominal musculature, so their bellies just hang out. And they also have lots of renal impairments. Okay, so this is the posterior urethral valve. So you can see why urine can't get out. This valve is preventing the flow of urine out the urethra, and that's why that bladder just filled completely up. Look at that. Pretty extreme. What's that? That's the ureter. And over time, because of all the retrograde flow of urine, it just loses the tone. Okay. Just a random fact. When we do kidney transplants, a lot of times we'll leave the kidney in just because they're so hard to get to. We'll leave the diseased one in, and then we do the transplant in front where it's easier to get to. But because of that, it's more prone to injury. Okay. Uh-oh. Okay. All right, NCLEX, what do you need to know about all these? Before you call the physician, make sure you check for kinks. All right, the most common problem with these is that these tubes can easily get kinked, whether it's a dialysis catheter or one of these urinary diversions. So that's what you need to know. Also, most of these kids are going to be on antibiotics prophylactically and antispasmodics. So that's just to help tone down the bladder after surgery. Okay. Yeah. It's redundant. Okay, you don't need to know about this, but I like these pictures. With polycystic kidney disease, there are actually two kinds. One has a good prognosis, one has a poor one. But essentially what happens, the kidney keeps producing these cysts, and over time they multiply, and they prevent the kidneys from functioning. So this is a real-life cystic kidney. And then these are adult ones, not kids, but pretty impressive. Okay, you don't need to know about this for the test. I just like the pictures. UTI, okay, you guys have had this in concepts. I'm not going to read these to you. You need to know this for NCLEX, so review it. The main thing that's different with kids, or that you need to know about kids, is that when kids start having accidents, the first thing we think of is they've got emotional problems. But before you send them off to the psychiatrist to be evaluated because they're having accidents, you want to just do a quick urine culture and rule that out first, because that's easy to fix. Okay, the rest is self-explanatory. Okay, just make sure you review those. I don't want to read them to you. Oh, one more thing. For infants, poor feeding is usually the first sign of a UTI. Okay. All right. What's the most common contributing factor to urinary tract infections? Urinary stasis, bladder hanging out in the urine hanging out in the bladder, and then enuresis is last thing, and then we're done. Enuresis, also known as bedwetting. You can have primary, meaning that you can never potty train them. Intermittent, sometimes they're continent, sometimes they're not. And secondary, something will cause them to not be continent after originally being potty trained. So it can be during the day, it can be at night, or it can be both, and it's very common. Up to 10% of kids have a problem with this, and we don't generally worry about it until they reach the age of 8, 9, sometimes 10. Okay. What do we do about it? It is a slow process, and you know, how many times do you read it in the newspaper about a little kiddo, like a child abuse case? A lot of times it comes back to this, right? Kids are beaten because they're having accidents, all right? There's no easy fix for this. A couple things you can do. You can treat them with a couple of different medications. One is DDAVP. Okay, DDAVP, we give that for hemophilia. I talked about it last time, but we also use this for DI, right? So it helps them decrease the urine output. A lot of times that's just reserved for sleepovers. You don't give it to them all the time, but it helps decrease the urine. But generally what you really need to know about this is that there's no easy fix, all right? And you have to do a lot of education with parents, behavior modification. I think I'm just going to leave it at that. Okay. Yeah, that's it. All right. If anybody wants to stay and ask questions about HEMONC, I'm happy to stay and talk to you guys. Okay.